Thank you very much. Good afternoon, everyone. So today we are going to present this study with the title Understanding the Medical Challenges in Diagnosis and Treating Bilateral Pitting Edema in Children, a Qualitative Study. So first of all, I would like to start by introducing what bilateral pitting edema is. So bilateral pitting edema is a typical sign of kwashiorkor, but is not exclusive to it. So it's important to make the difference between what we call nutritional edema, so the sign of kwashiorkor. So when we see skin changes, low plasma proteins, difficult to treat, high mortality, and relatively high weight for height zeta score compared to marasmus. But about kwashiorkor, next presentation we'll discuss more. And then what is the non-nutritional edema? So any kind of bilateral pitting edema from cardiac, renal, or hepatic condition. So it's very important to make a differential diagnosis among the two. So before conducting this qualitative study, Gian Benfarat and team conducted a quantitative study between 2017 and 2019 in two main countries, Mali and DRC, in which was shown high cases of prevalence of bilateral pitting edema with the children assessing MSF pediatric hospitals. And the study objective of this quantitative work was to describe the children that were assessing MSF pediatric hospital presenting with bilateral pitting edema. And the results were that half of them had acute malnutrition when measured by middle upper arm circumference, and then even more when was used the weight for height. And half of these children were anemic and hypotensive at admission, and there was high mortality, and especially in children that presented with proteinuria. But at the end of this study, health workers reported that it was very difficult to make a differential diagnosis. So it was kwashiorkor or was another type of bilateral pitting edema. And that's why the qualitative study came. And the main rationale for doing this study is that we know a little about the diagnosis of kwashiorkor and how to make a differential diagnosis with other bilateral pitting edemas. And there is also little qualitative work, especially working with health workers in low-income settings. And so how we can fill the gap? So we worked with local and international nurses and physicians, having a strong experience with patients presenting with bilateral pitting edema in the two countries of interest, Mali and DRC. So the study objectives were two. The first one was to understand the lived experience of health workers that were diagnosing and treating bilateral pitting edema in Rutshuru and in Kutiala. And the second objective was to identify the main challenges and strategies to improve their clinical outcomes. In terms of methods, so we used a qualitative approach with a participatory action research lens. We conducted 21 in-depth interviews and 2 focus group discussion with 25 health workers, including local and international staff. And then we analyzed these thematically using the PASS model, which you can see on the right side of this slide, in which there are 2 main domains, the social cultural context and the medical environment. And then the factors that are in this framework will be discussed during the results section. So first of all, here we start with the results. The health workers interpreted the bilateral pitting edema most of the time associated with kwashiorkor, so the nutritional edema. In terms of gravity, they said that they perceived that bilateral pitting edema was quite high in terms of gravity due to the access barriers, for example, the high cost, the transport, and also the use of traditional treatments prior to the biomedical care, and also due to the little parental involvement during the diagnosis. So it was difficult, for example, to understand the history of the patient when he was admitted in the hospitals. So in this quote that you can see here, there is a female health worker who reported how much is important to have the family involved to understand the history of the patient, and especially the men, because they are those that at the end they are going to take the decision for the children in terms of health. In terms of diagnostic challenges, the first one that was mentioned by the health workers was that the initial assessment of bilateral pink edema was most often done by nutrition assistants rather than physicians, and this created an overdiagnosis of kwashiorkor without really doing a differential diagnosis. Especially in DRC, was also found that there was a limited laboratory capacity, and this hindered the diagnosis confirmation. And as you can see in this quote from a male participant, he highlighted the difficulty of making the diagnosis of kwashiorkor and the grade of edema that each child presented. Then we have treatment challenges. So health workers reported that patients who were coming to the MSF hospital were already too sick. And because there was delays, there was misdiagnosis, and then those kind of patients often had complications such as sepsis, metabolic instability, and organ failure. And also they reported that patients said to them that there was a lot of confusion in the recommendation at the discharge of the patient. So there was, for example, a conflicting advice on the ready-to-use therapeutic food with or without home food, and this depended not just among the countries, so Mali and DRC, but also within the same team in the same countries. So the last part of our results is about the recommendation that health workers gave to us. So it came from focus group discussion with staff both from Mali and DRC, and they highlighted 4 main domains. The first one was prevention, standardization, staffing and training, and research. In terms of prevention, they said that it's very important to strengthen infant and young child feeding, and also doing more community engagement to avoid delays of children coming to the hospitals. In terms of standardization, they said that it's really needed for the diagnosis part to have unified diagnosis protocols and also history-taking templates. In terms of staffing and training, they said that they needed more skilled staff. They need also psychological support, not just for the children, but also for the family that were accompanying them. And last but not least, they talk about research, saying that kwashiorkor is particularly under-researched, so they need to know more about the pathophysiology and having so tailored treatments. In terms of recommendation, these also, because we continue to use from the beginning up to the end the participatory research approach. Then we discussed the main clinical recommendation among the research team, but also MSF advisor and operation, and we came up with the 5 main recommendations from there. So the first one is that every child that presents with a sign of malnutrition and bilateral pitting edema should start immediately nutrition treatment. The second one is the importance of ruling out other comorbidities, so to make the differential diagnosis. The third one is the importance of placing, if possible, those patients presenting with bilateral pitting edema nearby nursing station, so then there can be a vital sign monitoring every 3 hours if the context allows so. The fourth recommendation was about including community engagement and mobile clinics to sensitize patients and parents on bilateral pitting edema. And then finally, it was discussed that in any case, the care needs to be tailored to the child condition and to the context. So in conclusion, we can say that a multifactorial approach to manage the bilateral pitting edema is essential, and health worker must be the core to shape the responsive strategies. For sure, in terms of further research, there is still a lot to do in terms of understanding about kwashiorkor, and what came directly from our research is also like the importance of doing the analysis of community and caregiver perspective to understand better the social cultural context, and so tailor a more contextually relevant intervention to prevent and treat children presenting with bilateral pitting edema. And this is going to be it was not possible to do in our work because it was a COVID time, so I had to conduct all the interviews online. It was quite intense, and we couldn't include the community and caregivers. So this study has been recently published in PLOS Global Health Journal. And just to end, I would like to thank you, all the participants that participated in our study, without whom this study would not be possible, all the MSF team in DRC and Mali, Ministry of Health, Epicentre, and the University of Leeds who contributed to this work. Thank you.